Hello, I'm Charlotte Barker, and I'm here to present our poster about an atypical transmission of capnocytophaga in a splenectomized adult. Our case is a 60-year-old male with a history of traumatic splenectomy during childhood who presented with acute onset fever, malaise, upper abdominal pain, and chest pain. The symptoms started within 12 hours prior to the presentation. He also had frontal headache, right-sided neck pain, and one episode of vomiting at home. Past medical history was significant for hypertension, hypothyroidism, sleep apnea, and asthma. Surgical history was notable for appendectomy, splenectomy at 8 years old, hernia repair, and medial meniscus repair of left knee. Social history was notable for no tobacco, alcohol, or drug use. He lives with his wife and his pet Yorkshire Terrier, works for an electrical company, outside on line maintenance, and he enjoys gardening and working outside. Medications include lisinopril, hydrochlorothiazide, and levothyroxine. Of note, he reports that his pet dog frequently licks his face, and no dog bites or tick bites. He also denied any sick contacts. Physical exam was remarkable for a 60-year-old male in acute distress who was diaphoretic with rapid, shallow breaths. He had no scleral icterus, but he was noted to have facial flushing and subsequently developed facial petechiae, no dental lesions. He had a negative Kernick and Burditsky sign. He was tachypnic with shallow breathing, an audible upper airway noise. He was using accessory muscles with nasal flaring and belly breathing. He had right upper quadrant tenderness to palpation. Abdomen was non-distended. There was no rebound or guarding. Skin was notable for, again, facial flushing, as well as bilateral lower extremity pallor, but it was warm and well perfused, and he was found to have petechiae, as seen in Figure 3. No focal neurologic deficits were noted. Vital signs were significant for hypotension, 92/54, tachycardia, 111, respiratory rate of 33. He was 94% saturating on 1 liter nasal cannula. Temperature was 101.6. Lab work was significant for hemoglobin, 14.9, leukopenia, platelets of 160, coags with an INR of 2.4, LFTs unremarkable. He had an elevated creatinine. Troponins and lipase were negative, and his lactate was remarkably elevated in the ED, 9.1, even after 2 liters of IV fluids. The patient presented to the ICU. He was intubated and required 4 pressors to maintain his MAP. Blood cultures revealed rod bacteria within neutrophils, as seen in Figure 1. His overall ICU course was complicated by DIC, acute renal failure requiring dialysis, and shock liver. He was treated empirically with vancomycin, meropenem, metronidazole, and doxycycline. Initial attempts to isolate and identify the bacteria was challenging, as the organism grew poorly and slowly in culture. The rest of his infectious workup was negative for Legionella, Rickettsia, Ehrlichia, Leptospirosis, Anaplasma, Babesia, CMV, COVID, stool cultures, and C. diff were all negative. A CT adjuvant pelvin revealed enteritis. CT head and neck showed no abscess. On peripheral blood smear, his bacteria were visualized within the neutrophils, as previously mentioned, and eventually he underwent cell-free plasma sequencing, which revealed the culprit as capnocytophaga over a week after the initial blood cultures were drawn. He was continued on meropenem and transitioned to Augmentin on discharge. He was also weaned off dialysis and presented to acute rehab. Our case is interesting because this patient presented with profound septic shock due to capnocytophaga, which resulted in DIC and multi-organ failure. It's unique because the exposure to capnocytophaga was by licking from his pet dog, not by bite, and the diagnosis was difficult to make via culture and required cell-free plasma sequencing. This case should be remembered as important because capnocytophaga bacteremia should be suspected in any immunocompromised patient or asplenic patient with gram-negative rod bacteremia that's difficult to culture. Thank you for your time.